Hello, I am Professor Yang Seung-min. Even though you place an implant successfully, depending on how you manage the status of a patient, peri-implantitis may occur. It is very important to address the peri-implantitis at the beginning. In this lecture, we are going to talk about the risk factors of peri-implantitis. Today, I'm going to talk about these contents, the definition of a peri-implantitis, and the prevalence, the risk factors causing peri-implantitis. First, bacterial factors, host, the patient factors, prosthodontic factors, followed by the operator factors, which we do not like very much, and the summary. Definition of peri-implantitis, along with the prevalence. Generally, after implant is placed, peri-implantitis is checked. After the placement, in the middle of the contour, there's a gingival recession, and you may think it's not a big deal. However, if you look at the X-ray, you can see the bone loss, and if you remove the prosthesis, forms look different. If you look at the middle implant, keratinized gingiva is not sufficient, so is the vestibular depth. So there can be some risks. The biggest risk is this one. Calculus and plaque are accumulated quite a lot around the prosthesis. When it is not under proper management, calculus and plaque would be accumulated and tissue would respond to them. So they need to be removed to maintain the condition in a sound way. And we have different types of peri-implant diseases. First, we have the peri-implant mucositis. Only inflammation exists around the implant. On the X-ray, there is no bone loss observed, but there is some swelling due to inflammation. So it can be treated rather easily without losing bone. Peri-implantitis is an inflammation process that can be accompanied with bone loss. If you look at the posterior implants, you can see inflammation, and behind it on the X-ray, bone is lost. So this is called peri-implantitis. Regarding this, there are many different definitions by various scholars, and they have some consensus on the term. In 2018, world-renowned scholars got together and came up with the definition of peri-implantitis. There was some special thing. They talked about peri-implant health, and they defined it. When we define a disease, when the disease is developed and what the healthy condition is. So the healthy condition is defined, followed by the definitions of peri-implant mucositis and peri-implantitis. If opportunity comes, please look up the journal. But for those who do not have time, let me summarize what they say. As you can see here, what is important is it is associated with plaque. It is associated with the poor plaque control in patients who do not attend regular maintenance therapy. And anti-infective treatment strategies were successful. There are clinical signs of inflammation, bleeding, unprobing, and or suppuration, increased probing depths, and bone loss. So these are included in the definition. In the past, it was not clearly mentioned, but here it clarifies that the peri-implant mucositis is assumed to precede peri-implantitis. So if you observe peri-implant mucositis and address it, the progression to peri-implantitis, it can stop. Peri-implantitis seems to progress not in a linear way, but in an accelerating pattern. What does that mean? In the same patient or even in the same oral environment and prosthesis, peri-implantitis can accelerate. So if we can prevent the acceleration, we can control it. How to approach it is also covered, and regular checkup is recommended for people with a history of severe periodontitis. And oral hygiene control is very important, and if you consider them in the treatment, it will be very helpful. First, we need to give diagnosis to catch the situation. Peri-implant mucositis and peri-implantitis have commonalities, including a lot of plaque accumulation, gingival redness, and purulence, and bleeding on probing. So these are the commonalities between those two. And after that, we need to look at the bone loss on the X-ray. If there is bone loss, you can address it as a peri-implantitis. If there is no bone loss, it's peri-implant mucositis. Then, what is the prevalence of peri-implant diseases? According to the third EAO conference, many people came up with a definition. They said it would be an uprising tsunami of the problem. 10% of the implants placed and 20% of patients with implant placement would show peri-implant diseases. However, in the same year, the world-renowned scholars got together in a separate consensus meeting, which was sponsored by world-renowned implant manufacturers. So they may have had some bias, but still, the consensus concluded that we are too optimistic. The prevalence is not that serious. In the same year, the two groups gave contradictory results depending on how we define the disease and how we look at them. The result would be different. In my view, if we give accurate diagnosis and treat it properly, I believe this consensus meeting conclusion is right. Otherwise, the conclusion from the previous meeting would be right. So the perspective of peri-implantitis differs depending on how we plan, maintain, and place them. In our hospital, to clear up the confusion, we did a study. The study population is those who have been followed up for more than 5 years after implant placement, with bone loss of 2 millimeters or more, redness, and or suppuration, with 675 patients and 1,929 implants. In 10% of the patients and 7% of the implants, we observed peri-implantitis. This is lower to suggestions of EAO conference, and this is similar to Estopona conference. As I said before, how you maintain the implants, the results would become different. So this reflects that difference. Implants are, from the risk perspective, there is no single risk. There are a combination of risks, surgery-related, prosthetic-related, and patient-related factors, and they interact with each other, causing peri-implantitis as a result. So we cannot just look at one factor, we need to look at various factors. Risk factors, let's look at one by one. The first one, as I said before, calculus and plaque, the biological bacterial factor, that is a bone loss due to infection, which can be controlled to reduce the peri-implantitis. Development of dental biofilms, how they are accumulated. At the beginning, it is adsorption, followed by growth, maturation, and inflammation. Adsorption and growth can be stopped, then the cause of the problem can be removed. That means maintenance is very important. And we need to consider the host factors, patient factors, whether the patient has systemic diseases or periodontal disease, or the patient has poor oral hygiene. Various factors like this need to be considered as patient factors for peri-implantitis. So those who fall into these categories need to be made aware that they are prone to peri-implantitis. Implants are placed, then the prostheses were pretty good, and the bone is regenerated. About 3 years later, inflammation occurred. We were surprised what happened, but the patient smokes 2 packs a day. Smoking is a big risk factor for peri-implantitis. There's a national campaign against smoking, but that is not easy to change the habit. So if the patient doesn't stop smoking, the risk is there, and we need to make the patients aware of the problem. So we need to do the checkup pretty often. Considering various risk factors, the frequency of peri-implantitis is about 20% in the general patient level, but 36% in smokers, almost the double. So that is the prevalence of peri-implantitis. We need to understand this. To heavy smokers, you need to shorten the maintenance frequency. We need to consider prosthodontic factors. This is a paper published in 2020. Here, the emergence angle is between the tangent of the transitional contour relative to the long axis of the implant. It is about the emergence angle and its relations to peri-implantitis prevalence, whether the angle is more than 30 degrees or less than that, or if the emergence profile is straight, convex, or concave. And various implant types, including the diameter, they're all summarized here. If the angle is 30 degrees or lower, that is better. If it is less than 30 degrees, there's no problem if the emergence profile is concave or straight, but if it is convex, it is red. And if it is higher than 30 degrees, concave is better. Bridge or single type prosthesis is considered. And if it is a bridge type, the middle implant is prone to peri-implantitis. The conclusion of the report is like this. The implant shapes are varied. Cervical part is not applicable because the cervical part has already defined emergence profile. So we cannot distinguish them based on 30 degrees of emergence profile. So they may not be applicable. Implants can be attached in a screw-retained or cement-retained way. The cement-retained approach may have residual cement problem like here. If there is excess cement, that can cause peri-implantitis later. Despite our efforts to remove the cement, often they cannot be completely removed. So you need to find ways to remove the residual cement. You may fabricate a prosthesis combining cement retained and screw retained. Or prosthesis can be connected after removing all the cement extraorally first. Or gingiva margin can be made equi or supramargin so that cement can be removed. When we do surgery, this can come up. Implants should not be too close with each other. If implants develop some problem and if we are to explant it and place another one, in the past we used to have 2 implants placed in a narrow space in the most posterior area. As they are too close, oral hygiene will become poor. It looks good at the beginning, but over time, bone loss is bound to happen. I was wondering what to do, but an opportunity came. A tooth at number 6 broke, so we planned to place an implant there, and the number 8 is decided to be removed. The lost bone is regenerated. After the regeneration, prosthesis is connected again, and it is used up to now without a problem. If we left it alone without making corrections, I believe the most posterior number 7 would have developed the bone loss and could have been explanted due to large bone loss. So if we take action in advance for the risk factor, we will be able to control the site to prevent peri-implantitis. Let's summarize. Keep in mind, all implants can develop peri-implantitis. We need to identify the risk factors for peri-implantitis, and if we address or reduce the risk factors, implants can be maintained very stably and healthy. We tend to ignore the fact that a lot of risks are iatrogenic. The decisions that we make for surgeries, we need to adhere to the principles for surgery to reduce the operator risks. Unless the implant presents discomfort clearly, quite often peri-implantitis is found after much progress. So successful implant procedure is important, but regular checkup is also very important to increase the patient satisfaction. This concludes my lecture. Thank you for your attention.